Hello, welcome to Cherokee Now. Today we have Eric Metterhausen joining the show. Eric is a pharmacist with the Cherokee Indian Hospital Authority. Eric, welcome to the show.
Thank you. Thank you.
So tell me a little bit about your role as a pharmacist at the hospital, how long you've been helping the public.
So I've been at Cherokee about 5.5 years now, and about 3.5 years ago I started working primarily out in the clinic. We now have integrated care team, or the patient-centered medical home, out in the clinic where patients have access not just to their primary care provider and their nursing staff, but also a pharmacist, behavioral health consultant, and nutritionist as well.
Okay, so what is a day like for a pharmacist? Tell me what you do in a day.
So for me, most of my time spent managing high blood pressure, managing diabetes, managing high cholesterol, and then some of asthma and medication reconciliations and things like that. But those first three are the main disease states that I work on managing for patients.
When a patient comes in, they work with a doctor or a physician, and then they also work with you on the medicine on the back end? Is that kind of how?
Yeah, and then if I'd seen them that day, oftentimes they're not necessarily able to follow up with their primary care provider every 2 to 4 weeks, depending on their situation, if they're somewhat out of control. Okay. But I'm able to usually fit them into my schedule that quickly. So both myself and the primary care provider will kind of initiate the therapy, and then I'll usually follow up till we get them to their goal.
Okay, excellent. Yeah. So one of the issues we've been hearing about recently deals with a drug called Metformin. What is Metformin, and who would use Metformin?
So Metformin's the first-line medication for most type 2 diabetic patients. And we're using that to help lower the A1C or lower the blood sugars, and it's very rare for that one to actually cause any low blood sugars for patients when it's used by itself, which is one of the reasons we go with that one initially. And it's also been shown in some studies to potentially even reduce the risk of death for patients when they're taking it as well.
Okay. How long has Metformin existed?
For a really long time, well over 30 years, so very well studied. And,
so it's studied and stabilized. And what are some of the, we're getting into that, what are some of the misconceptions that exist with the use of Metformin we've heard recently? So
one thing I hear from patients all the time is that they knew someone who was on Metformin, that person then developed cirrhosis or advanced liver disease, and they were taken off Metformin. And it's pretty easy to kind of draw that conclusion, oh, I was on Metformin, I got this liver disease, and now my doctor took me off Metformin. It's easy to draw that conclusion, hey, maybe the Metformin caused the issue. But that's not the reason why the Metformin was stopped. So Metformin hasn't been shown to cause liver disease, but the way that Metformin works is it works in the liver. So one of the primary ways that the liver impacts diabetes is it produces new sugar for your body. So it's always working to produce sugar. Okay. And the way that Metformin works is to slow down that production of sugar. And one of those substrates, or the things that your body uses to build that sugar, is called lactate, or lactic acid is another more common term for it. And when you get to advanced liver disease, your liver is not producing sugar as well as it normally would, so you can get a little buildup of that lactate. And similar, if you're on Metformin, you can get a little bit of buildup of that lactate as well. So if we ever have the combination of both, we can get too much of a buildup in that lactate, or lead to lactic acidosis, or too high of levels for that.
Gotcha.
So in those circumstances, it wasn't that the Metformin caused the liver disease, it was just the provider was concerned, oh, your liver's not functioning as well as it was before. Right. We might build up lactic acid, and you're on Metformin at the same time might build up too much, so we've got to take that.
So you're just looking at an alternative method at that point.
So at that point we're moving away from the Metformin, looking at other treatment options.
Okay. So what side effects do exist with the Metformin, and what should people do to take precautions when using this medication?
So the most common issue with Metformin is diarrhea, especially with the original tablet that was a fast-acting tablet. Up to 50% of people had some issues with diarrhea initially when they started taking it, and about 25% with some nausea issues. Now, as it's been around longer, they made long-acting versions of the Metformin, which we have available at the hospital now, and that reduces that diarrhea rate down to about 10%, the nausea rate down to 7%, but still a real concern. But we have other methods that help decrease that risk as well. So one is not starting at the maximum dose of the medication right away, but starting at a low dose, making sure your body tolerates that for a while. If you're doing well, a week later, increasing, and then continuing that process till we get up to where we need to be. And then the other thing we do is make sure you take the medication with food. and that helps settle the stomach a little bit as well.
Okay, so through the years, they've upgraded, I guess, or updated the formula in the metformin to get it to a point where it's really, the side effects are minimal now. They do exist, and there are other treatments available to the public for with type 2 diabetes. Is that correct?
Yeah, so metformin is not the only option. It's usually our first line option because the most effective oral tablet or tablet you're taking by mouth, not dealing with injections at the time. And like I said earlier, that really low risk of going too low on your blood sugar, which is often a large concern for diabetics.
What so knowing there's a lot of concern in the community regarding liver disease and that metformin is not in fact the cause, what can people in the community do to decrease the risks of getting and acquiring liver disease?
So one of the most important things, first of all, is just being in contact with your healthcare team, making sure you make appointments and take care of any issues you've got with them. But as long as it's not an alcohol-induced liver disease, for that obviously you would avoid alcohol. But if it's kind of a fatty liver disease or something like that that can develop from high blood sugars and things like that, you want to work on your exercise and diet, try to lose weight if you're overweight or obese, keep your blood pressure controlled, keep your cholesterol controlled, keep your sugars controlled and everything like that. And that's what you can really do to decrease that risk of getting fatty liver disease or it progressing.
Okay, so if you're like me, I don't go regularly to the hospital, which I should. What do you recommend? What should a person in their 30s and 40s? How often should they be attending the hospital and getting regular checkups?
So probably at least once a year, just to make sure everything's going okay. But if you're not able to make it that often, trying to make sure you're at least at a healthy weight.
Okay.
And you can, even if you're not at the hospital, if you're passing by another pharmacy, you can they usually have blood pressure cuffs. You can see if that's doing okay. And there's other screening events.
But that's the biggie,
done.
just checking your blood pressure and making sure that that's kind of in line with natural, normal.
Yeah, that levels. And your blood sugars and cholesterol, which the blood sugars and cholesterol usually you have to
get the blood work done.
Yeah.
Okay. Well, I probably need to get caught up on that. I'm a little bit behind. Well, good. Well, I appreciate you coming in. Tell me a little bit more about the integrated care team. I know that was something that was kind of new to the hospital and to the way that you guys handle healthcare in within the tribe here. Tell me a little bit about that.
Yeah, so about 3 years ago we started. It used to be you had your provider, but you didn't necessarily have a whole team working for you. So now we have the provider, your nursing staff, and then each provider also has an assigned nutritionist, pharmacist, and behavioral health consultant, which are all there to help you. So even if you don't know that person yet, if you're impaneled to a primary care provider at the hospital, you have a pharmacist that's assigned to you, you have a nutritionist, you have a behavioral health consultant. And
you're able to speak with them at any time you come up for your visit?
Yeah, pretty much any time. We're not, as a pharmacist, I'm no longer based in the pharmacy. I'm out in clinic all the time, just like the nutritionist and behavioral health consultant. So even if you had a concern today, you can always walk up to the primary care desk and ask if one of us is available.
And what we may not see behind the scenes is the fact that you guys are communicating right there in a smaller pod, right? An office together?
Correct. Yeah, we're in a big open workspace. So whenever I see, like, for example, one of Dr. Wolf's patients, I'll talk to her about it afterwards and send her the progress note. So, and we keep in tune with each other.
Everybody stays tuned in to what's happening.
Yeah, and if something comes up that's beyond my normal scope, if I'm talking to someone about diabetes, but some other concern comes up that I'm not trained or qualified to handle, then I just go ahead and bring her in.
That's really good to know that there's a whole team of folks working behind the scenes on every patient's care and needs, and the various different needs that we have in the community. Yeah, that all of you guys are on the same page working together across the bar. Yeah. Okay, is there anything else that you'd like to share with us today?
No, I think that's the main points I was trying to get
thanks
across.
For coming on and tell us a lot about metformin. That really clears up a lot of the air, I guess, about some of the misconceptions. And anytime we can get together and chat about any of these kind of issues, please come on with us.
Great, thank you very much.
All right, so thanks for joining us, Eric. Anytime you have news to share regarding the medicines we prescribe to people, please feel free to come on and share that. We want a healthy community, and knowledge about these things can help for sure. That'll be it for today. If you're listening at home and would like to comment on the show or ask questions regarding what we discussed today, please comment on our EBCI Cherokee Now Facebook page at facebook.com/Cherokee Now. We'll see you again soon. Data Dog Hungry.